So, yeah. So thank you, Pak John. Okay. Yeah. Okay, so good morning, Dr. Rutter.
Good morning.
So thank you so much for coming today, but please let me open this session by giving an instruction to all of our Indonesian audience to switch on their Bahasa Indonesia interpretation feature. Actually, more people will come during the session as well. So selamat malam semuanya. Silakan untuk membaca instruksi yang telah ditulis di dalam chat box. Mungkin Via bisa bantu tulis instruction-nya di dalam chat box. Cara mengaktifkan fitur interpretasi. Jadi pertama-tama kalau ingin mendengar terjemahannya bisa klik interpretation, di bawah ada yang bentuk globe. Lalu jika ada, kalau nggak ada tampilan bola dunianya, tolong klik icon 3 titik, lalu pilih bahasa Indonesia kalau memang mau mendengarkannya dalam terjemahan bahasa Indonesia. Bapak Ibu juga nggak perlu klik mute original audio saat mendengarkan penerjemahan. Jadi saat penerjemah merubah bahasa, Bapak Ibu bisa langsung mendengarin. Oke, selanjutnya saya akan melanjutkan acaranya dalam bahasa Inggris. Bismillah. Oke, good morning, Dr. Rutter, and good evening, everyone. Especially good morning for Dr. Rutter in Cincinnati. Welcome, everyone, to our third Q&A session. My name is Tia. I'm the founder of Enabled, a community support platform in Indonesia. I'm also one of the administrators for the tracheostomy care group in the WhatsApp group. Okay, I'm here with Dr. Michael Rutter, a pediatric otolaryngologist from Cincinnati Children's Hospital in the United States of America. So we are really thrilled to have you all join us today as we explore and learn about tracheostomy. Over the next 1.5 hours, we will learn from our expert here, Dr. Rutter, about the best practices, especially in tracheostomy care. Hopefully, after this, it can help us better understand our children. Okay, without further ado, Doctor, I think I will start with the first question. First of all, we want to know about you, Dr. Rutter. More specifically, the specific questions from the parents. They want to know how many of your patients that have been successfully decannulated, and what are the major diagnoses of the patients that are successfully decannulated. Please, Doctor.
So thank you very much for the invitation to be part of this conversation. Just as an aside, while I work in America, I actually grew up in New Zealand, but originally I was born in Indonesia, in Kediri. And so great to be back. Our group is abnormal because we get sent an awful lot of children with challenging airway problems and tracheotomies. And of course, we place a lot of tracheotomies as well. We've a set decannulation protocol, and typically we decannulate about 40 children a year. And it's very variable depending on what the problem is. And so probably the most common thing that we deal with is subglottic stenosis. But we also see many children who've been trached for prematurity and eventually are able to have the tracheotomy removed without needing other surgery. We also see congenital problems such as laryngeal clefts and tracheal stenosis. And so it's a wide variety of things that we deal with, but probably the most common is a narrowing below the vocal cords called a subglottic stenosis.
Okay, that's very interesting. It's actually one of the major diagnoses as well in Indonesia, besides dysphagia, actually. So when we're talking about you, Dr. Rutter, and we're hearing about the good news, especially from patients that have gone abroad to the US, for example, they've mentioned that they've seen much progress from their children after they got treatment from you. Actually, what can we expect to happen if we bring our children to you after for example, our children has done the tracheostomy procedure, hoping for them to be decannulated someday?
I think the key there is, why did they have the tracheotomy placed in the first place? And so we have some children where we placed a tracheotomy with no expectation that it will ever be removed. So if you've got a severe neuromuscular problem, like spinal muscular atrophy type 1, if your trach goes in, realistically, it's never going to come out. If you've got a severe problem neurologically, you've had a period with not enough oxygen when you were born, hypoxic ischemic encephalopathy, then it may not be a good idea to ever remove your tracheotomy, because you may not have enough drive to breathe well on your own. A child who's on a ventilator needs a tracheotomy to be able to have the ventilation delivered to them. Having said that, most of the children we are sent have a tracheotomy, have a fixable anatomical problem that, if it can be fixed, the tracheotomy can then be removed. And in that sense, our job is to evaluate the children and optimize them and get them as good as we can get them before we do an operation to try and remove the tracheotomy. And in some children, they don't even need an operation to remove the tracheotomy. They just need to be optimized. So again, very variable. If you chronically aspirate, if everything that you put in your mouth ends up wanting to go to your lungs, you shouldn't have a tracheotomy removed. So there are groups of children, and in children sent to us where the intent is to try and remove the tracheotomy tube and there's not an obvious reason not to, I think we do reasonably well in assisting them on that journey.
Okay, so actually it very depends on why the tracheostomy itself has been done, yeah, doctor, to the patient. Okay, so you mentioned about you will do, for example, evaluation to the patients before you finally, for example, doing airway reconstruction, so on and so forth. My question is, what are the assessments that you are doing, especially for dysphagia patients, until you make a decision that yes, tracheostomy is the solution for this baby or these children?
So we start our evaluation process before the child even comes to us. And so often there's a lot in the history, the questions we ask, that can help give us a good idea to that. And so, for example, the children that we are concerned may have aspiration problems, they have repeated pneumonias. Their oxygen levels are slowly dropping as time goes by. If your oxygen levels are at 98% when you're well 1 year, and the next year they're 94%, and the next year they're 92%, and whenever you get a cough or a cold, you need oxygen, and the next year you need oxygen all the time, you're aspirating till proven otherwise. And so one of the tests that we can do that is very simple and that any of you can do at home is go to your local store or supermarket and buy a small bottle of green food dye. And if you put a drop of green food dye in anything that your child is eating or drinking, and if you later suck green out of the tracheotomy tube, they're aspirating. If you put a drop of green food dye in their gastrostomy tube feeds, and later on you suck green out of their trach, they have reflux and they're aspirating. If you put a drop of green food dye on their tongue, and then later you see green coming out of their trach tube, they're aspirating saliva. And this is very physiological. All of the tests that we do in a hospital are a window in time. They tell you about what is happening on the day you do that test. And if your child is very upset while that test is being done, it doesn't necessarily tell you about how things normally are. And it will also, doing this will also let you know things that are at risk of being aspirated. And for example, thin fluids drunk fast are the most likely thing to be aspirated. And so if you find that solids and purees given slowly, you're not sucking green out the trach tube, then you know that that's safe. And it may be that just some things need to be limited. And so again, this is a very physiological, simple test that anyone can do if a child has a tracheotomy and assuming they don't have a total blockage in their airway above the trach tube. Then once the child actually gets to us, we tend to do a very comprehensive evaluation. And so that will involve a FEES examination. That stands for a functional endoscopic evaluation of swallowing. That means that, you know, the little boy, the little girl is sitting on your knee, wide awake. We run a skinny telescope down their nose and give them something to eat or drink and see what happens with it. It may include a VSS or video swallow study, an X-ray of swallowing. It might include a CT scan of the lungs, because that will tell you about the past in terms of whether they've had chronic aspiration. It would include doing what we call a triple scope. It would be pulmonary, doing a flexible bronchoscopy, ENT, like me, doing a rigid bronchoscopy, and gastroenterology doing an esophagogastroduodenoscopy. And we do that all at the same time to try and see what else might be going on with the child's airway. And so we do a very comprehensive evaluation. If the child has particular needs, like say a heart problem, we would get them evaluated by our cardiologist at the same time. Often we would have our anaesthetists meet them before the surgery just to be sure that things are as safe as possible before we put them to sleep to do the scopes. And so we do a really very comprehensive evaluation, but that's usually after we've done a very comprehensive intake where we ask a lot of questions about the child. So we often know a lot about these children before they even arrive. And because we deal with a lot of complex children, we have a certain degree of pattern recognition. If you have charge syndrome, you are very likely to have an aspiration problem, and we would assume that till proven otherwise. If you have a mucopolysaccharidosis, we know you've got a risk of anesthetic problems and that you've probably got significant sleep apnea. If you've got Rubinstein-Taybi syndrome, if you've got Down syndrome, we sort of know the things to look for in those specific children.
So it's very interesting how comprehensive the procedure that you are doing with your team, because you mentioned several things, and one of the things that I'm familiar with is actually FEES, the FEES. You know, it's pretty common in Indonesia, but usually FEES is in Indonesia is being done after the tracheostomy procedure has been done. So what happened, for example, in my case, the doctor was using the RFL. It's the laryngoscopic, the flexible one, yeah. And then the doctor decided that my baby aspirated a lot, and that's why she required tracheostomy. But then after she had a tracheostomy procedure, and then after 2 months we were testing the fees. But I don't know whether yeah, because it's maybe in Indonesia we haven't been as comprehensive as what has been done in the US, but I think it's a pretty great lesson as well for us to learn, because we really hope in Indonesia the team of doctors can also be well coordinated, like the one in the US or in the Singapore, so we can treat the patients better. So thank you, doctor, for the information. This is one question about, especially about the aspiration itself. So most of the cases in Asia, they have the swallowing problems. The saliva of our children usually kept falling to the voice box, and that's why we need tracheostomy to suction the saliva, to keep the saliva stop falling into the airway. And the routines that we usually do is that we visit the doctors, for example, every month to change the tracheostomy tube, and having, in my case, doing the laryngoscopy, the RFL1. But for the other patients, they have to be sedated, staying in the hospital, doing in the surgery room, doing bronchoscopy. My question is, I always ask the doctor what kind of things that I can do to help my baby to get better, other than visiting the doctor every month and doing physiotherapy a couple days a week. But it seems that there is no other thing that we can do. My question is there's nothing more that we can do to help these children be better, other than doing physiotherapy and then changing the tracheostomy tube each month?
So you've asked quite a few different questions there, and I'm going to try and tackle some things one at a time. So the first thing I'm going to tackle is, let's think about aspiration, because that is one of the primary reasons for not wishing to take a tracheotomy tube out. So we talked about doing food dye testing at home, which will tell you how badly your child is aspirating and whether they are aspirating on everything. And the key here is, if you think about aspiration, there are three things that you can aspirate. You can aspirate food and drink. You can aspirate saliva. You can aspirate gastroesophageal reflux from your stomach. And so we talked about how you could food dye test all of those things to test those. Each of those has its own set of tests that can be run. And then it's a question of, why are you aspirating? And so the commonest group of children who aspirate have an neurological problem. I didn't have enough oxygen when I was born, and my brain sustained an injury because of that. I have a syndrome where I've got neurological issues. And so neurological is the most common, and it's the most difficult to fix. Some of these things can greatly improve with time on their own. So again, charge syndrome is a very good example, where if you're aspirating, the expectation is that in most children, not in everyone, but in most children, it's going to improve with time. And then you've got another group, which is having an anatomical problem. Do I have a tracheoesophageal fistula? Do I have a laryngeal cleft? Do I have scarring in my esophagus, so when things go down, they don't fully go down and they tend to well up and fall over into my larynx? Do I have a vocal cord paralysis on one side of my larynx? Do I have scarring in my throat that predisposes to things going the wrong way? And so we are very good at fixing anatomical problems. We can fix some physiological problems or neurological problems. And so an example there is, if you have a child who appears to be a normal child without an anatomical problem, but they're still aspirating, and If you do an MRI scan, you can look for a particular problem called a Chiari malformation. And that is something that is surgically correctable. And so, again, you're trying to steer through why are you aspirating? So it's what do you aspirate? How can I test for it? Why are you aspirating? Can I do anything about it? And remember, Cincinnati, I know that you are comparing us to Indonesia, but we're different from the rest of America as well. So I'm not, this is a journey that we are trying to take the world through in terms of delivering aerodigested medicine and trying to help more than just children in Indonesia. It's trying to help a lot of other places, including within America. So most of our tracheotomy children, and I look after many, many children with tracheotomies, literally hundreds. Our routine is that we would like the trach changed once every 2 weeks if it is what's called a single lumen tube. Now, some of you may be familiar with adult tracheotomy tubes, which have an inner cannula. If you've got an inner cannula, you can change that as many times a day as you need to, but the outer cannula only gets changed every few months. Most children have a single lumen tube. It's in one piece, you have to change the whole thing. And we initially, when we place a tracheotomy, we teach the parents to suction the tube. We teach them how to change the tube. We have to have 2 responsible adults who can prove that they can change a tube before we let the child go home. They have to have the right supplies at home, suction machines, oxygen, a pulse oximeter. We'd like them to be on a monitor at night if possible. Where possible, we'd like to have someone in the room with the child who's awake at night. So in America, we actually sometimes can get nurses to do that paid for by insurance companies, which is not possible in most of the world. We encourage that the trach tube is changed by the parents at home every 2 weeks. That is our routine, and that is what is typically done with 95 to 98% of our patients. We have a very small number of patients where the trach change is done in the hospital, but there are very unusual extenuating circumstances when that's the case. So the vast majority of our patients, the trach is changed at home with 2 responsible adults present if possible. This is about safety. If a trach tube falls out, your child can die. And trach tubes fall out. And particularly there are some children who, it's a great way of grabbing attention. They pull the trach out. And so we really always want them around someone who's capable of putting the trach tube back in. And so we are very focused on training.
Wow. So I just wonder, how long usually do the parents take for the training itself? Do they usually stay for, you observe them, for example, 2 weeks of being capable of changing it themselves, or what?
It's usually more like 2 days. The reasons our patients stay in hospital longer is not so much the trach changes, because you can learn that fairly fast. It's getting everything set up at home. And in the American system, our delays are more a factor of getting all the home equipment provided by the company that will provide it and trying to provide additional home care in terms of do you want a nurse in your home at night so you can sleep? And so the aspects of that can take significantly longer, particularly if the child is, say, on a ventilator as well. So there's a lot of other factors at play, but usually the actual training of how to change a trach. So, we put a trach in day one. In our hospital, if you're not on a ventilator, you don't even go to the intensive care unit. We actually have a trach ward, so you just go there. And we change the ties on the trach on day 3. The medical staff changes the trach itself on day 5. And then we start training the parents and basically get them to change the trach several times till they're both comfortable, or whoever the other caregivers in the household may be. And it's not a lengthy process. And to be fair, we have the advantage that we are a centre that looks after so many patients with trachs. It's part of the culture here. So this is not necessarily appropriate for every place, but all of our nurses are completely comfortable changing trachs. All of the doctors are. And you've got a ward of parents, all of whom are comfortable changing trachs. And so the whole environment for the families is, it's just a trach change. And all of the other parents feel the same way. And so in that sense, particularly given that this is all about safety for the child, it's not an issue for us, but in very unusual circumstances.
Is there any specific case that a child may not change their trach tube at home? Is there any, like, for example, for the stenosis patient, for example?
So the stenosis patients, most tracheal stenosis is above the trach tube, so irrelevant. The 2 circumstances that I can think of off the top of my head that we've recently dealt with is there was a child with scarring in the back of the trachea, and you had to bend the tip of the trach tube so it would slide in more forward. So it was a more difficult trach change. The second circumstance is that we had a teenage girl whose parents were extremely nervous, and in the end, she was actually going to college, and I sat her down in my consultation room in clinic, and I don't even see most of my trach tube kids in clinic, and basically said, "So, honey, we are going to change your trach 20 times in the next 20 minutes, and you're going to do it, and your father isn't, and once you've done that, you will be able to go to college and look after it yourself." Which is what we did. And so her parents are no longer involved. She does all her trach changes. She is living life large in college. She's having a great time. And, it was an investment of time worth doing. So again, unusual circumstances.
Wow, it's very heartrending for me to hear that from you, sir, because I think in this case, especially in Indonesia, we cannot even talk about changing the tracheostomy tubes. I mean, parents doing it themselves. Most of the parents here cannot even see their children staying in the ICU. Just to give you some sense, most of our children usually are staying in the the NICU or PICU, and most of the parents cannot see them, even not they cannot see them. Usually they can see from the windows, especially during the lunchtime and all that. They cannot even see them, let alone helping for example, the nurses or doctors changing the tracheostomy tubes. I think it's going to be a big change if we can do.
And this is really a cultural statement.
Yeah.
Every country is different, every hospital is different, and the history of how places got to where they are is often relevant. And so I'm not trying to tell you what to do.
Yeah.
I'm telling you what we do.
Yes.
And whether some of that is translatable is really up to you and the culture in your hospital. And so our intensive care units, the parents are at the bedside every day. We encourage it. We have a chair that turns into a bed so the parents can sleep in the room. But that's not always the case in every place. And so, again, there are pros and cons to each approach. There are times where we have problems where families can get critical of our staff or try and do things that for their child that actually interfere with what we wish to do. But that's unusual. And so there's a lot of different circumstances in terms of how you can manage patients and manage families. And generally speaking, we would prefer the families to be very involved. And generally speaking, children are happier to have their families present. But again, there are a lot of circumstances with this sort of thing. So I'm not trying to say this is how it should be done. I'm trying to say this is the way we choose to do it. This is one alternative way that things could be done.
Yeah, that's actually what we believe to be the best as well. But I think probably the hospitals in Indonesia probably have different reason why they don't, execute that way. Okay, so you mentioned that the tracheostomy tubes are being changed every 2 weeks, right, at home, for example, by the parents. My question is because right now in Indonesia, we have experienced tracheostomy tube scarcity, and we wonder if we can reuse the tracheostomy tube that used before by the children.
So there's a worldwide shortage of tracheostomy tubes at the moment, particularly the silicone tubes. The supply chains are finally improving, so we expect that this is going to be resolved relatively soon. Because of that, there are guidelines for the major tracheotomy tube manufacturers at the moment. And so Traco, Bivona, Shiley, and so yes, you can reuse tubes. And usually the recommendation is that a single tube can be reused up to, depending on the manufacturer, around about 6 times. And so usually this would be, you need at least 2 tubes. One of them is in the child, one of them is being cleaned and getting ready to be used again. In terms of the level of cleanliness, often the term that we use is restaurant level cleanliness. And so hot, soapy water and cleaning it, having something that can go through the tube, not just the outside. And so the old-fashioned pipe cleaners used to be ideal for this, though they are rather hard to find at the moment. But you need something you can pass through the tube and clean it out. And then the key is to let it dry completely and then store it in a sealed plastic bag or something like that. But the key is getting it as dry as you can. Do not put it in an oven to dry it. Just let it air dry. And so, and you could even use a hairdryer on a cool setting if you wanted to. But it's basically thoroughly clean it, dry it, store it, reuse it, and try and keep track of how many times you've done that. Tubes don't last forever. Even if you've not used it 6 times, but it looks like it's not, it's cracking or there's something like that, don't use it again. Throw it away and get another one. And so, so those are sort of the guidelines that we use at the moment. We would prefer a new tube every 2 weeks. We are pragmatic. It's very difficult to do that at the moment. And so reusing tubes is reasonable.
Okay. Wow. So if the parents change the tubes at home by themselves, how often do they have to visit you and for what purpose, doctor?
normally what we would like to do, so in children with a chronic tracheotomy tube, where the realistic expectation that it's going to be removed is either far in the future or we're not expecting to have to remove it, we would usually like to do an evaluation in the operating room where we check that the trachea is healthy, that there's not a big suprastomal granuloma, for example. We want to check that the trach tube is the appropriate size, that it's not rubbing on the wall of the trachea at the front or the back. And typically we'd like to do that evaluation, depending on the child and the age of the child, once a year or once every 2 years, with the child briefly asleep in the operating room. This varies a lot depending on what the child has going on. So, for example, if you have a child who's got a mild subglottic stenosis that I'm doing balloon dilation on to see if we can fix it so that they can have their tracheotomy removed, if I'm doing balloon dilations, I would normally do that every 1 to 2 weeks on 3 or 4 occasions. So you might get a little run of evaluations in the operating room, if need be. And so, again, so much of this is individualized care. You have a guideline, but the individual needs of the patient are more important than the guideline you're using.
Okay, so thank you, doctor. Next question is about HME, or the heat moisture exchanger, the one that is being put in front of the tracheostomy tube. Is it mandatory for especially the pediatric tracheostomy patients?
So the risk of tracheotomy tubes is that they plug, and that they fill with mucus and that you can't breathe properly. The highest risk for that happening is that mucus inside the tube gets dry, and the solution to that is making sure things stay humidified. And so you do have a great advantage in Indonesia that you have a lot of humidity anyway. And so the risk for your patients in Indonesia, frankly, is in homes with excellent air conditioning, because the atmosphere is far drier. And so the HME, the little barrel thing that you put on the trach tube, is purely designed to keep the humidity up within the trachea and the trach tube, so you don't get secretions thickening and drying and a risk of plugging. And so, yes, we very much encourage that. Remember that America, particularly at this time of the year, is a far drier environment, so it's more important for us than for you. But the risk in Indonesia isn't so much when you're out and about, it's when you're in a well air-conditioned house, which is a far drier environment. And so it's purely keep things moist. This is what, for you and I, our mouth and our nose do. It's humidifying the air going into our lungs. With a trach tube, you bypass all of that. And so the HME is trying to compensate for that.
Okay, so we understand that you encourage us to wear the HME, I mean, for the patients. What is actually the side effect of not wearing that? I mean, other than, having the unfiltered air intake, is it going to ruin the lung tissue, so on and so forth?
No, I mean, so the two risks are, one, something gets in there from the outside environment that shouldn't. A mosquito flies in or something. But that's pretty unlikely. The main thing is humidity. It's just keeping things moist so that you don't end up with thick, dry secretions in your airway. And that can have consequences in terms of respiratory obstruction and stasis, and therefore a slightly higher risk of infections. So the most important thing is the humidity. And again, in some children who really do not want to wear an HME, and most children can be trained to wear one, you can put saline drops down the tube and try and compensate to keep things moist.
Okay, understood. I also learned that when I took care of my daughter, we have a proper log just to help us to better understand our child. Do the patients there, especially the parents, do they use certain tools to help them, logging their activities of their children, for example, the suction conditions, so on and so forth?
It's not part of our routine, so not a requirement for us as physicians caring for children. Interestingly, the companies that supply the nursing staff to help look after a child at home, so say a night nurse while the parents sleep, they are required to fill in a sort of an hourly evaluation of what is going on. But I think that's more for the benefit of the company than the benefit of the child, if I could put it in that sense.
Understood. So it's not actually that, impactful to the children's development, so on and so forth, yeah, doctor.
It's unusual that it changes management or changes the outcome in a significant way in the majority of children. There's always exceptions, but.
Okay. It's also another question that I'm actually curious about the patients in the US. Do they have to cover all the costs as well? I mean, because we have so many costs that we have to bear here. For example, the medical supplies and the ones that I previously mentioned to you that we have to go to the clinics to change the tracheostomy tube. How about patients in the US?
So it's a simple question with a very complicated answer. So in the US, about 50% of our patients are insured. In other words, the parents work for a company where part of their compensation package includes health insurance, and the health insurance company, in America the term is third-party payers, will pay for all of the care for that child. Then your other 50% are families without those resources, and in the vast majority of them, they are covered by something called Medicaid, which is a form of welfare provided by the government. And so we really do not expect that cost is a significant barrier to our patients. Interestingly, the biggest costs actually to the families are of patients who have insurance, but not a great insurance policy. So, for example, they have the term as a copay. They have to pay a proportion of the medical charges up to a certain amount. So, for example, in some insurance plans, you have to have a 10% copay. So for every $10 that gets charged to the patient, the insurance company will cover $9, but the family has to cover $1, which doesn't seem much. But if the annual bill is $100,000, it adds up. And usually there's an annual threshold to that as well. And so one of the things we sometimes see is families getting close to meeting their deductible, which means the amount of money that they are liable for in a one-year period. And so, often towards the end of a calendar year, so in November or December, some families will say, look, if you need to do anything, do it now. We've met our deductible. We don't have any other costs that we will have to bear. But generally speaking, families do carry a small financial burden, but not a big financial burden. The flip side of that is society carries a big financial burden, the percentage of the GDP spent on health in America is very, very large. But a lot of this is through insurance companies and Medicaid.
Yeah, so it's very fortunate that most of them are being covered by insurance, usually from their employer, yeah, doctor. Okay. Now I want to move to the swallowing problem discussion. So as I previously mentioned, most of us here our children have swallowing problems, and most of them are using the NGT, the nasogastric or oral gastric tube. The question is, do these tubes, the nasogastric or oral gastric tubes, worsen the aspiration of the saliva to the airway?
So having a nasogastric tube does not improve your swallowing. It makes it slightly worse, but it's a small effect. And so if you swapped a nasogastric tube to a gastrostomy tube, it will help a little bit, but not a lot in terms of your ability to swallow. With nasogastric tubes, how long do you need a nasogastric tube? And so the factors at play there are, do you have a realistic expectation that swallowing will improve? And so, for example, if you have a child with severe neurological problems, they were born at 26 weeks gestation, they didn't have enough oxygen when they were born, and they are going to have lifelong neurological problems, cerebral palsy, and they've got a significant aspiration tendency. Realistically, they're never going to feed by mouth for a very long time. In that sense, why leave a nasogastric tube in for a year? You might as well go and put a gastrostomy tube in relatively early. You've lost that battle. Move on. If, however, you think that there's a realistic chance that your child is going to learn to swallow, then the nasogastric tube may just be a temporary bridge to get you there. And in that sense, we will sometimes tolerate a nasogastric tube for 6 or 12 months. If it's been there for more than a year, I think it's worth taking a step back and saying, look, are we moving forward or not? Should we be thinking about doing something else, like a gastrostomy tube? Now, remember, if you have a child with a tracheotomy, you can dye test. And so even though you're not in a hospital and you're not with a therapist, and those things are good, but make no mistake, but at home, you don't want to end up having a child with oral aversions. If you take nothing by mouth for a very long time, you start to not want anything in your mouth. And so early on, it's worth starting to work with tastes to keep the child interested. Maybe start a small amount of purees. And if they're not aspirating and you can dye test it, then you may be able to help your child swallow enough to not need a nasogastric tube. And so we try to promote that, getting families involved. I mean, if you've got a tracheotomy tube, particularly if you dye test, you will know if they aspirate. And if you can start a child feeding, and maybe they can't manage thin fluids fast, maybe the fluids still need to go down the nasogastric tube, but the more you practice, the more you can do, and the more you can move forward. And the key is moving forward.
Okay, so you mentioned that probably if we understand that this, for example, this child has a severe neurological problem and we expect them to have it to use the feeding tube long term, then maybe we can go directly to the PAC, for example. But if we want to give a try, for example, for a year, then that could be an enough observation, yeah, doctor, for us to decide whether we can switch to PAC. Is that correct? So about a year is the longest time for a person.
I mean, a year as an example, there is nothing black and white here.
Okay.
And so in a child where there's no realistic expectation that they will take enough by mouth anytime soon, there's no point leaving a nasogastric tube in for 2 years.
Yeah.
Put a gastrostomy tube in.
Yeah.
In a child where you think they've got a realistic chance that they will not need feeding through a tube long term, then it's worth tolerating a nasogastric tube. A year is often just a good time to step back and think, are we making progress? And so it's an arbitrary number. It's a purely arbitrary number.
Okay.
But if at a year you haven't moved forward, all food and drink is going down the nasogastric tube, then you may want to be thinking of an alternative. And particularly in a child with a tracheotomy, you should already know if they're aspirating by then if you do food dye testing.
Yeah.
And you should be able to have worked with your child to try and see what they are able to do. And just standing still doesn't work nearly as well as trying to move forward. Okay.
So actually, some of the doctors are trying to recommend the parents to switch to the PAC, to the gastro tube. But some parents are being reluctant because, they have certain trauma, especially after their baby has done the tracheostomy procedure, so on and so forth. The question is, what is actually the impact of the prolonged NGT or oral gastric tube if they don't switch to PAC?
So if you have a nasogastric tube for a very long time, one, you're more prone to having stomach reflux. Two, it does have a small negative impact on swallowing. And three, it's just tougher on the child having a tube in their nose the whole time and having to have it replaced occasionally. So it's more the bigger picture of why are you doing this and where are you going? And so if this is going to take a long time, years and years, you're better off with a gastrostomy tube. If you think it's a temporary bridge, then work on the child's swallowing to see if you can actually get rid of that tube.
Okay. It's actually one of the problems as well, since our children, they don't really use their mouth, right, to consume. And we think that their jaw muscles are being tightened and very hard to open. And it's very confusing on how to help the doctors opening the tightened jaw. For example, when the teeth are broken or something like that. How can we help to treat the tightened jaw when for example, when the teeth are broken and the doctor requires them to open their mouth widely?
So it's actually quite unusual. It's most children don't have a problem with mouth opening. It's relatively unusual. And most of the time there may be some underlying problems that the child has. So charge syndrome would be one of those. Pierre-Robin syndrome at times, particularly some forms of distraction, may help get your trach out, which in turn may help with your feeding, but depending on how it's done, it may cause problems with the jaw joint, the temporomandibular joint. And so in most children, mouth opening is not your issue. Again, it's also a reason to try and encourage feeding. If you have a trach and you can dye test, you know whether you've got an aspiration problem. If you don't, keep trying to feed. And the more the child does, the better for the child and for everyone else concerned.
Okay, okay. So I previously asked about for example, the impact of prolonged use of tubes. I have another question is that what is the is there any negative impact on prolonged tracheostomy use, for example?
So prolonged tracheotomy use, let's look at extremes because it often helps crystallize the question. So I've had some children who've been utterly trach dependent and say they're 10 years old. They've had a total blockage in their airway. They've been unable to speak. They've been completely trach dependent, but otherwise they're pretty good. And I've done an operation where I have removed the narrowing in the trachea. I've taken the trach out on the day of surgery. We've got a breathing tube in their nose, which we take out the following day. And so we've done the operation on a Tuesday. On the Monday, trach dependent, unable to talk, been that way for 12 years. On the Wednesday, sitting up in bed, talking in full sentences for the first time in their life, because talking is partly about your brain, can you form words, and partly about your anatomy. If we can give you the conduit to get air through your vocal cords, so that's one extreme. The flip side of that, so in that sense, that extreme is that even though this child had a trach for many, many, many years, once the trach was out, they don't carry their baggage. They don't have longer-term problems from the trach once it's gone. The flip side of that is tracheotomies are life-saving. When you put a trach in, you do it for a reason. And usually it is to get a patient off a ventilator, get them out of a hospital, and allow them to survive. The downside is that tracheotomies are dangerous. Every year, we have children die a trach-related death. Every year, we lose a few of our patients. And this can be because the trach accidentally displaced at night while the child was asleep and no one knew. And in the morning you come in and your child's gone. This may be because the child was playing and pulled the tube out and no one was around to realize that they were having a breathing problem and nothing could be done about it. So trach tubes are dangerous. And so my job, while I put a lot of trachs in children because they need them at that time, most of my job is trying to prevent the need for a trach or trying to remove a trach. And some children, they need a trach. There's just no doubt they need a trach. But in children who otherwise, particularly developmentally, don't need a trach, I try and prevent the need for one or remove one as soon as I possibly can, because they are innately slightly risky.
I just want to get some sense, Dr. Rutter, how long people in general use the tracheostomy, especially when they use the tracheostomy since they were baby, for example?
Again, it's highly individualized. So I've had children sent to me with trachs who were 2 months old, and I've taken the trach out before they were 3 months old. I've had children who have come to me, adults who've come to me, where I've, taken the trach out years later. And so it's not the age of the child, it's their underlying problems. And remember, there are some children, particularly with distal or lower tracheal problems, where a tracheotomy can cause as many problems as it fixes. And so sometimes I've had to do operations to take a tracheotomy out of a child. And so I think the smallest, youngest kid I've taken a tracheotomy out of had a narrow trachea due to complete tracheal rings and a subglottic stenosis and a very short tracheotomy tube that was that long. And they weighed 2.5 kilograms. And they were not yet term. They were still premature. And I did an operation, open chest, cardiac bypass. I repaired the trachea, doing a slide tracheoplasty. I repaired the subglottic stenosis, taking some rib cartilage and putting grafts at the front and the back of the larynx, and intubated the child afterwards, took the trach out, intubated the child for, I think, 2 days afterwards, and then took the breathing tube out, and the child was fine at 2.5 kilograms. And I mean, they were born at 33 weeks gestation, and I operated on them when they were 3 weeks old. So they were still a premature baby at that point. So it's not the age of the child, it's not the size of the child, it's the problems the child has. There's not a fixed guideline. Now, if you've got a premature baby who couldn't get extubated and has had a tracheotomy placed, typically we work to get the trach tube out between 1 and 2 years of age. And that very much depends on, are they still on a ventilator? Do they have subglottic stenosis? Is their airway swollen or active? Are they developmentally in a state where taking the tracheotomy out would be a good idea? So again, you've got a guideline and you've got an individual patient-directed modification of the guideline. So this is what we typically do, but for you, this is what we're going to do.
Okay, so I think we understand that it's very important to understand the underlying problem why a person has to go through a tracheostomy procedure. My question is, do we really have a specific, like a plan, like a decannulation plan? Like, can we predict when someone can be decannulated? For example, this baby has a stenosis, then we can predict probably it's about in 1 to 2 years. As long as they reach certain milestones, then we can say that they are ready for decannulation.
So I'm going to tackle this on 3 different fronts. So if you're born with a narrowing, so you have a congenital stenosis and you need a trach, some of those children will grow out of it on their own. And often a year or 2 later, you can take the tracheotomy out without having any other surgery. Not very common. If you have an acquired stenosis, I was a baby and I was intubated for 3 months and they couldn't get the tube out, and then I had a tracheotomy placed. And I've now got a narrowing in my airway, a subglottic stenosis. The odds that that will get better on its own are very, very low, and you're probably going to need to do a surgery to fix it. And typically, and again, there's always exceptions to this, but usually between 1 and 2 years of age, we're starting to think, are we ready to proceed with an operation to try and get the trach out? The third aspect of this is that in a child with a trach, we want to be very sure you don't need it before we take it away. And so often we will do an operation where we fixed the stenosis and things look good, but we still want to be sure that you don't need a tracheotomy. And so typically what we do is, if we think things are good, we'll do a bronchoscopy, have a look, check that things look good, put in a much smaller trach tube than the child normally has, so a 3.0 or a 2.5, and cap it, put a plug on it, and watch the child in the hospital for 2 nights. And if they do well for those 48 hours, we'll send them home capped or plugged day and night for several weeks. And if they've done well over that time, not using the trach tube, ideally having had a cough or a cold over that time, we'll then bring them back, have another look, be sure that there's no other problems like a suprastomal granuloma has appeared, and then take the trach out and watch them 2 nights. And if they do absolutely fine, we send them home and we bring them back again another 6 or 8 weeks later and have another look and be sure that the hole has healed on its own. And if there's still a small hole remaining, we'll bring them back another 6 or 8 weeks later and remove the hole. So we have a set protocol of how we approach this. And the philosophy behind it is you've got to earn it. We want to be absolutely sure you don't need a trach tube before we take it away.
Okay, so it's very interesting. Actually, for each cause of wearing a tracheostomy, there is actually a protocol on how to make sure that these patients are ready to be decannulated. So, wow, it's very interesting that there is such a protocol. There is a protocol for that, because I think in my experience when I took care of my daughter, it seems that tracheostomy is something that is very unpredictable. Like, how can I tell that my baby is improving or not? Is my baby getting worse or not? It's something that is unpredictable, but it's very interesting that actually there is a protocol to get some sense whether our children are progressing or not. One of the question is that most of the patients here, the doctors mentioned that they cannot be decannulated because they have problem with the neck control. So they cannot really, sit up, and they cannot really, they cannot really have their neck, being straight. The question is, how can we help these children to fix this neck control other than physiotherapy? Maybe you can have any suggestions other than physiotherapy?
So neck control is potentially relevant if you have salivary management problems, particularly the term is social drooling. If you lean forward, saliva falls out of your mouth. And again, control to help you get your neck back will help saliva go the right way down your esophagus. This is not helpful if you aspirate saliva. This is not relevant in terms of whether you need a tracheotomy or not. And so, generally speaking, neck control is relevant if you have social drooling, saliva falls out of your mouth. Neck control is not particularly relevant from my standpoint for whether you aspirate saliva or whether you need or don't need a tracheotomy tube.
Okay, well noted, doctor, about that. I just wonder, in this healthcare industry, as observation, are there any, upcoming plans in this industry to improve, especially the clinical outcomes for the tracheostomy patients, as far as you understand?
There is continuous change. The world moves forward. In the time that I have been doing what I do, we've established the concept of aerodigestive teams, where we look after complex children with a team that involves a pulmonologist, an ENT surgeon, a gastroenterologist, a pediatric surgeon. And so that's moved forward immensely. The design of tracheotomy tubes, we helped develop the extended collar tube that's quite common nowadays. I've developed probably 20 new operations over the last few years. So things move forward, and you now have a bigger range of tracheotomy tube designs. You've got new operations. You've got the use of topical medications. So again, I'll give you a couple of examples of things that I've done over the years. If you have a problem of skin having wetness issues, so a drooler where your chin skin is not very healthy, chapstick works really well. It's cheap. You can't overdose on it. You can put it around a trach site. You can put it around a G-tube site. You can put it on your chin. So wherever you've got a wetness issue, that can be useful. We have ear drops that contain an antibiotic and a steroid. The name we use is Ciprodex, but there's different versions around the world. We found that this works really well. Put down a trach tube. If you've got smelly secretions, if you've got blood-tinged secretions. And so there's a lot of things that have moved forward and will continue to move forward. On the flip side of that is we're seeing far more children with tracheotomies. And the reason for that is that 25 years ago, a lot of the children that we now see with tracheotomy tubes would not have survived 25 years ago. Neonatal care is far better. And so while that means you've got, a lot more children who survived, you also have more children with special needs, including tracheotomy. And so we see sort of both things competing against each other.
Okay. Yeah, you mentioned that, for example, when you're treating a tracheostomy patient, you involve also other specialists related to the patient's condition. I wonder, are you as the ENT doctor, because the patient has a tracheostomy procedure, are you being the leader of the doctor's team, or is there like one coordinator for the doctor's team to work together, or is there a technology that helps you coordinate?
We developed the first aerodigestive team in the world. Since then, in America alone, there's probably now 48 other aerodigestive teams, and each is a little bit different. And this is also true for the aerodigestive teams being established around the world at the moment. And they're very patient-centric, and they serve the needs of their local community. And so for us, ENT tends to be the lead because a lot of the patients that we see have subglottic stenosis or a tracheal problem. And we work very collaboratively with our pulmonologists and GI colleagues, and increasingly with our pediatric surgical colleagues, because we're now looking after a lot of children with esophageal problems as well. And so this is very individualized. There are some teams that really focus on, say, sleep apnea, or on aspiration, or on children with cerebral palsy. So there are, each team has its particular focus that meets the needs of the children that it serves. And but having said that, collaborative care is far better than it was 20 years ago, and is rapidly becoming the standard of care.
Okay, noted, doctor. I have, I think, probably one to two questions before we close the session. I want to take the questions from the patients actually that I have listed. So the first question from this patient is that her daughter, I think, her child is being fully capped right now. So the tracheostomy tube is being fully capped. And she's asking whether it's the thing that actually stop her children from snoring and retracting during deep sleep. Probably the children have sleep apnea, doctor.
So the key here is, if you cap your trach tube and you're snoring and retracting, you're obstructed. If you uncap it and everything gets better, you've still got a source of obstruction. There are two possible sources of obstruction. One is that the trach tube is too big, And therefore, when you plug it, air is struggling to get round the sides of the trach tube beside the wall of the trachea. And the other is that upstream, you've got a problem of obstruction. So how can you work out which one is which? So if you've got a capped trach tube and you're snoring and retracting, and you uncap it and everything's better, and then you put in a smaller trach tube and you cap it and you're not snoring and obstructing, then it's the size of the trach tube is the issue. But if you put in a smaller trach tube and you're still snoring and retracting, it's not the size of the trach tube. It means you've got another problem. Now, if it's a typical snore, statistically, it's usually tonsils and adenoids. If it's a stridor snore, that usually means it's a laryngeal or subglottic problem that you probably want to have resolved before you take the trach out. And frankly, if your child is snoring and retracting plugged, they shouldn't be plugged. You've got a problem. Resolve it before you do that.
Okay. Okay. Yeah, one more question actually. So her child is 5 years old, and actually the reason for the tracheostomy procedure is not because of her condition. So her condition is actually heart failure due to mitral valve damage. But she had to go through a tracheostomy tube because of the prolonged ventilator use. She is quite concerned because right now the doctor is recommending her to decannulate the child, but then she sees that her child is still often, turns blue, often out of breath, so on and so forth, and she's concerned that taking out the tracheostomy tube will actually make her life even more difficult. So what do you think, doctor?
So you've got a child who's got a heart problem and they've got an airway problem. And this is all about communication. And your ENT surgeon and your cardiologist need to communicate, because if you're having blue spells, something is wrong. And so, what did the most recent cardiac echo show? And if you've got pulmonary hypertension, and again, I am missing information here, because mitral valve damage, you should have, I assume, replaced the mitral valve. But there's more going on than that, because you shouldn't have pulmonary hypertension and you shouldn't be turning blue. Something else is going on cardiac-wise. And so if you have pulmonary hypertension, you do not want to be having blue spells, because that's going to make your pulmonary hypertension worse. And therefore, you shouldn't have your tracheotomy removed till that is resolved. And so the key there is your ENT doctor and your cardiologist ideally need to have a conversation with each other and make sure they're on the same page. Because what you're telling me, taking the trach out does not seem like a good idea till this is resolved, because it may make the cardiac condition worse.
Yeah. Okay. Actually, I just want to take this one last question, and after that we will close the session tonight, doctor. So this one last question is, does tracheostomy tube size affects slime production? Because there is one case that she changed the tracheostomy tube size, I think 3 times, and the baby shows different conditions. And she's wondering if the tracheostomy tube size is the one that is affecting the slime production.
This is a very individualized thing. So basically, this depends on the age of the child and the size of the tube. And it's whether you are breathing through the tube and nowhere else, or whether you can also breathe around the tube. And so the size of the tube per se does not, affect the amount of mucus you make. But a small tube, it's far harder for the child to cough and clear. So you can't clear it out as well. So it's not that you're making more, it's that you can't get it out. And so generally speaking, if you are struggling with mucus problems with a trach, put in a bigger trach as a general rule of thumb. And so, yeah, I mean, the simple answer is put in a bigger trach.
Yeah, put on a bigger trach if because it's when I heard about the case, it sounds like scary, because it's not only about the slime is being much more than the previous size, but she got fever as well, and then recurring pneumonia, so on and so forth. So yeah, I think it's something that something that should be consulted with the ENT doctor, especially about the tracheostomy tube size. Okay, doctor, unfortunately, that was the last question that we have today. But before we leave, Dr. RUTTER, would you mind taking pictures with the patients here? So,
of course.
Okay, so everyone, if you don't mind, maybe you can switch on your camera so we can take the pictures together with Dr. RUTTER. Unfortunately, we cannot cover all the questions, but hopefully we can make another session like this, because there are so many questions, doctor, and thank you so much for helping us today. Via, let me know when you're ready ya. Maybe you can unmute yourself.
Oke, teman-teman bisa nyalain kameranya sekarang.
Via, maybe you can speak in English so Dr. RUTTER can tell the ini juga ya.
Okay, everyone, you can turn on your camera now because I'm gonna screenshot it. I'm gonna wait 1 or 2 seconds. Okay. Is everyone ready? Okay, I'm gonna take a screenshot. 1, 2, 3. One more. 1, 2, 3. I guess that's all. Thank you all for coming.
Okay, so thank you all for joining us today for this insightful session. We hope that you have found the information shared here valuable, then it will help you in caring for your lovely children. First of all, I'm sorry if there are any shortcomings in executing this session. And finally, I would like to thank Dr. Michael RUTTER for your time and expertise, and Ibu Nadia Bilondatu for interpreting to all of our audience today. We appreciate your contribution to this session and the valuable insights you shared with us. So thank you again for joining us, and we hope to see you at our future sessions. Have a great day, everyone. Thank you.
Thank you very much for the insight. Terima kasih, and have a very good day.
Thank you. Terima kasih, Dr. RUTTER. Bye-bye.
Bye-bye.